Pamela Villarreal, who's a senior fellow at the National Center for Policy Analysis, and she is its in-house expert on retirement, Social Security, economic growth, and tax issues. In this paper, in this issue, she teamed with John Goodman of the Center on a very interesting paper on the social costs of adverse events. In her other endeavors, she has written studies and analyses on topics such as Social Security, disability, the future of Social Security and Medicaid, and so on. And we're delighted Pamela could be with us today.
Thank you for having me. It's an honor to be here today. I'm Pam Villarreal with the National Center for Policy Analysis. My co-authors and I, we wrote an article on the social cost of adverse medical events and what can be done about it. There have been many estimates on the cost of adverse events, typically the cost of treating them, the value of lost productivity when patients experience them, and the cost of the malpractice system in dealing with events deemed to be negligent. But my co-authors and I take a slightly different approach in measuring the cost of adverse events. First of all, we looked at adverse events in a very well-known study that was done by Harvard back in the early 90s. It was about 31,000 patient records. And what they found was that 3.7% of those records had an adverse event. More than half of them were preventable, although not negligent. An example of this type of adverse event might be a hospital-acquired infection. And then, of course, the remainder of adverse events, about 28%, were considered negligent, which will be, say, operating on the wrong limb or leaving sponges in a patient after an operation. The problem with the medical malpractice system is we're only concerned with not killing 28% of the pie, but we don't really have as much concern about killing the people in the rest of the pie. So there was another study of hospital records in Utah, Colorado that also found an adverse event rate of about 2.9%. And then more recently, a Society of Actuaries study found an even higher rate of about 7%, with 22% of those adverse events being preventable. So in general, your chance of dying in a hospital from an adverse event is about 1 in 200 to 1 in 500. Amazingly, these rates are much higher than the risk of 1 in a million considered acceptable by government agencies such as the Environmental Protection Agency, but little is being done about it. So what we did was we wanted to measure how much do these adverse events cost, not just in treating them and in the tort system, but how much do they cost in the value of life and limb. So what we did, we used the value of a statistical life. Kit Viscusi and Joseph Aldi have done a lot of research and extensive studies in determining the value of statistical life. This is something that is typically used by government agencies in determining the cost and benefit, say the cost of preventing pollution or cleaning up something, depending on the value of the life that it will benefit. The typical value of a statistical life is $8.2 million. And since these are age adjusted because they are based on the willingness of people to take on higher wages as they take on more risk, so they're obviously based on the labor market, so they will be smaller for younger ages, and then they peak at age 35 to 44, and then they'll fall off. Now, obviously, in their studies, they did not have a value of statistical life for people under the age of 18 or people over 62, because they're not typically in the labor market. But what we did in order to calculate, we did assign half the value of the closest age group. So for those under 18, we assigned half the value of the 18 to 22-year-olds. And then for the above 62-year-olds, we assigned half the value of that age group for the elderly. So in order to calculate the number of deaths and injuries that occur, we used 2006 hospital admission data, which was actually the most recent we had when we started doing this study back at the end of 2009. we were able to use this data and to look at how many hospital admission days each age group spent. So we were able to not only age adjust the value of statistical life, but we were able to age adjust the probability of each age group experiencing an injury or an adverse event. And what we came up with was our lower estimate. We came up with about 71,180 adverse events each year for a total for a cost of $336 billion. For deaths, I'm sorry, that was actually deaths, I'm sorry. For injuries, we came up with about 1 million each year for a cost of $56.5 billion. So for total deaths and injuries, at a minimum, they cost society about $393 billion. If you look at additional numbers of adverse events, for example, the Centers for Disease Control estimate that outside of our numbers that we got from the New York and Colorado studies, they believe that about 99,000 people a year die from hospital-acquired infections. If you account for some overlap, you would actually come out with a maximum of about 187,000 deaths at a cost of $884 billion in lives lost per year. And then if you look at the recent Society of Actuaries study and account for the deaths that occurred in our New York study, you will find that there's about 6.1 million injuries as our upper estimate at a cost of $73.5 billion. So in general, the total cost of deaths and injuries is $393 billion to $958 billion a year. These are 2006 dollars. And so what that meant in 2006 was that for every dollar spent in the healthcare system, about 18 to 45 cents of that dollar was spent harming someone. So we've come up with a solution. One problem is with the current malpractice system, it doesn't really compensate the people that need it. Most people who are experiencing an adverse event that would really be worthy of going to the tort system never file a claim. Less than 2% that do file a claim get compensated. And of those who do get compensated, for every $1 spent in the tort system, the patient gets less than 50 cents. So this is obviously a very unfair and a very inefficient system. So what we advocate is for each patient to be able to be compensated for an adverse event regardless of fault. In this type of system, we would have the legislature actually establish contracts that would be fair and easy to read. And then that way the patient could receive compensation, say about $200,000 if they experience a death, their family could receive that, or they could receive, say, $20,000 per injury. The thing about this type of system is it would compensate people based on adverse events regardless of fault, so it would encourage more disclosure. The problem is with the system now is because physicians are often afraid of being sued, they have the incentive to hide errors and not disclose this type of thing. And additionally, patients would have the option to purchase additional insurance. Say if they feel like that their life will be worth more than $200,000, they would have the option of purchasing additional insurance such as we have in the life insurance industry. Currently, estimates of the cost of malpractice, including defensive medicine, run from about $50 billion to $250 billion. But if you were to compensate each injury an average of $20,000, and this would actually vary more or less depending on the severity of the injury. And if you were to compensate each adverse event death, then you would have about $200,000. Then this would cost about $150 billion, which will be the midpoint of what we're spending now. So it's not the cheapest way to compensate people, but I think that it will encourage more disclosure, it will improve quality, and it will actually get the money to the patients who are truly injured. Thank you.